research professor and program director at Drexel University. She's a licensed independent marriage and family therapist with supervision designation in Ohio. She's experienced teaching motivational interviewing to graduate level trainees across multiple programs and utilizes motivational interviewing principles in her own practice. She has extensive experience presenting on topics related to mental health and substance abuse. Sorry. So the format for the Echoes, if you haven't done one before, is there will be a 20 to 30-minute presentation by Dr. Patton where she's just presenting didactic information. After that, if you have any questions, we'll open it up. And then there will be a case presentation where we'll encourage you to unmute at that point. And you can either type questions in the chat or you can just open up and ask questions yourself about the topic or about the case. So for the time being during her presentation, if you would just sort of keep yourself muted, just so in case there's some extraneous background noises. All right, so, and just so you know, we are recording. I think you saw that pop up on your screen, so you know that. And also just be aware that the details for the case presentation have been modified. So we're not presenting a real person here. We're not, divulging any personal information. So, all right, with that, I'm going to turn it over to Dr. Patton.
Thank you so much, Sue, for that warm welcome. And it's lovely to see all of you today. It feels like I haven't seen your face in such a long time. So that made my heart warm. I will, as Sue outlined, I will start with the didactic. I'm wondering if Denise could give me host privileges real quick so I can share my screen. Sorry, I should have checked that sooner. And while that's happening, quick question for the group, and we can just put this in the chat. What words or ideas or thoughts come to mind for you when you hear motivational interviewing? Just if you want to put in the chat, just automatic thought, what comes to mind? Oh, awesome. Love it. So, okay, there's all kinds of stuff flowing in. Wonderful. So, ideas about being patient-driven or patient-centered, substance use or alcohol drug treatment modality, motivational interviewing got its home and problematic alcohol use, but it's been expanded a lot. Collaboration expert, all kinds of wonderful things. So we are definitely working with some key terms definitely popped up as you all outlined what comes to mind for you. Key terms that are really related to motivational interviewing. Thank you for sharing that. So in addition to that, it wouldn't be an MI presentation without a scaling question, right? So the question really is, on a scale of 1 to 10, with 1 being 0 experience with MI and 10 being I am an expert in MI, how experienced are you in using motivational interviewing in your practice? And again, you can just put this in the chat and see where we're at as a group. Awesome. Okay. So we have a really interesting mix here together today. And oh, this is exciting because we have folks ranging from the bottom to close to the top. I think we'll definitely be able to learn together today and share what we're all bringing to the table related to MI. Awesome. Thank you guys for sharing your numbers. For me, I would probably also be somewhere around a 7. I didn't get introduced to motivational interviewing until my postdoctoral fellowship at University of Michigan. And I was introduced to motivational interviewing through, specifically through Espert and using it as an Espert tool. Love it and have done additional trainings and practice since then. I think it's a great tool for behavioral change and to add to our repertoire as health professions and helping folks navigate towards better wellness. So without further ado, let's talk about motivational interviewing. And this is going to be a review for some of you. For some of you, it'll be maybe some new information or information that maybe you haven't connected the dots before. But here's our outline. We'll talk about motivational interviewing, why even bother using it. And then we're really going to focus in on motivational interviewing with older adults. What are some of the nuances to consider? Where are we at in terms of current research trends with MI and older adults? And then we'll pause for discussion before we transition to a case. Okay, so in a nutshell, what is motivational interviewing? You all did a wonderful job capturing the essence in your first share in the chat. But in a nutshell, the way for us to describe it is it's really a conversation about change. It's helping our patients, our clients, anyone who's experiencing ambivalence to make a decision about change. Ultimately, the goal is really about resolving the ambivalence. It's also a collaborative model, collaborative approach, very person-centered. We take a non-expert stance, and we're a guide. We're not a director, we're not a follower. We're a guide along the journey towards resolving the ambivalence and making decision and making change. In addition to that, a key component of MI is evoking or being evocative. And the whole rationale for this is that our goal is to help our clients align with their own motivation, their own commitment to change, for them to really go inward, listen to themselves, and feel empowered in their ability, their efficacy to make the change that they want to see. And with that, it's really about helping our clients tap into the resources and their ability that they already have. We're going to help them see it. So key term with motivational interviewing is ambivalence. Oh, the dreaded ambivalence. I always say, oh, ambivalence, like sometimes it feels like the worst thing in the world, right? Because we are in this stuck place on the fence between living with status quo, which in a lot of times status quo is comparable, but it also causes discomfort, and change. And humans, we don't like change. We like status quo. We like to maintain homeostasis. Change can be difficult and hard, even if it's positive. So ambivalence is this place of discomfort that's when we're stuck on the fence between, do we stay the same or do we make a change? And with that, we know that ambivalence can cause discomfort, which can lead to anxiety, which can lead us to avoidance or procrastination. And a lot of times folks review that as resistance. Our clients or patients are being resistant. And we want to back that up from an MI lens to say, there's a lot of discomfort here, and we don't like discomfort. So folks are avoiding. How can we help navigate through the discomfort to get to a place of decision? And we know it's important to address ambivalence. If we can address ambivalence, then we can address the ripple effect that ambivalence has. Increased ambivalence, we know it's linked to increased physical and mental health symptoms, decreased happiness, less life satisfaction, increased pain, increased isolation, increased stress, lots of heavy stuff. So if we can help our clients resolve their ambivalence, the hope is the ripple effect onto their overall quality of life. So let's talk about some of the key components within MI that we want to consider when we're using in practice. First is the spirit of MI, right? This is the kind of the essence of the model and how we approach it. One way to remember the spirit of MI is through PACE, P-A-C-E, which is these 4 components of partnership, acceptance, compassion, and evoking. So from the lens of partnership, our goal is to work for and with our client, our patient. It is a collaboration. We're both bringing different expertise to the table, and we're going to work together to come up with a solution. Acceptance is honoring our client and where their worth, their autonomy, their potential, their strengths. Compassion is promoting our client's welfare. It's prioritizing what is it that they need and want out of this process. And evoking is the strategy of identifying the motivation and resources that the client already has in place. And with all of this within the spirit of MI, it's about approaching it from this spirit to elicit change talk and commitment to change. Ultimately, that's what it boils down to. So within the spirit of MI, we can think about the processes that exist in the implementation of MI with our clients. I know it's outlined kind of linearly. It's recognizing all of these are interrelated and interconnected, and sometimes you go back and forth or they overlap. But we'll talk about the processes just so we're all on the same page with them. So first is engaging. So this is building your therapeutic alliance. It's establishing that trustworthy relationship between provider and patient. And for us as providers to really be engaging and listening to understand what's going on with our client, how are they perceiving things, how are they feeling, what are they thinking, get a holistic understanding of that. Once we have an alliance, we can move on to focusing. And this is where we really work towards a clear direction, a clear focus that we'll be able to set an agenda, goals, and priorities around. And once we have a focus, we're really going to home in on evoking. We're using strategies for change talk all throughout, but in evoking, it's really focused on eliciting the client's own motivation to change, their own change talk, so that they can move towards increased commitment to change and thus behavioral change related to. And after that, we move into planning. And this is where we have the opportunity to develop a clear plan to outline next steps for implementing behavioral change and maintaining it. And in my training some time ago, one way that it was outlined is, if we think about engaging, it's like, shall we walk together? Are we both ready to do this? What focusing is, where are we going? Evoking is why, go there. And planning is the how. So it's another way to think about the processes as they're outlined for MI. And with MI, we have our spirit that we want to keep in mind continuously. We have the processes, knowing where we're at in the process of guiding our clients. And then we have core skills that we can take into consideration. Core skills, another mnemonic here is ORS. So in motivational interviewing, we focus on open-ended questions, affirmations, reflections, and summaries. And we'll give a few examples real quick. So open-ended questions are the questions that really open up opportunity for our clients to talk with us, to open up the space for them, to give them voice. So it is things like, what was that like for you? Tell me a little bit more about that. Can you tell me more about this? What makes this time the time that you want to make the change? Just opening up dialogue versus closed-ended questions, which sometimes might be yes, no, or might be multiple choice, or ask for specific information like what's your address. Our goal with MI is to use more open-ended questions. We want to open up that space to give voice to our patient. And then for the A, or affirmations, it's really about infusing statements in our dialogue, in our conversation, that highlights the positives that we can point out to our clients. So this can look all kinds of different ways too, right? It can be some way of emphasizing a strength, or noticing that they did something positive, a positive action. These can be really helpful in strengthening our therapeutic relationship as long as they're authentic. And it can be a helpful way for us to help our client build in self-efficacy and self-confidence by using affirmations. There's some examples on the right there. And the third core skills, reflections. Reflections are key in MI. And reflections are statements. They are not questions. And they're statements that reflect back to the client what they're thinking or feeling in a way that conveys that we understand and that we have empathy for what our client is experiencing. And there are so many ways to reflect back. It's super fun to reflect back because there are a lot of different options. It can be as simple as just repeating back what the client said. Or it can be more complicated, like it can be the use of metaphor. It can be the use of reflecting the feeling back, or amplifying what they said, making it bigger than what they said. There are a lot of different ways we can use reflection. The idea behind reflection is us stating it back to the client is they're then going to hear what they're saying. They may not be hearing it otherwise. So they can start owning those change talk statements and use that to increase their commitment to change. The last core skill, as listed in ORS anyway, is the summary. I was always trying to think of it as the beautiful bouquet of flowers, right? That Each reflection is a flower, and summary is our way of taking all of those and synthesizing them into a beautiful bouquet that we can give back to the client. And it really is just a longer reflection that highlights both sides of the ambivalence. And we want to strategically end with the change talk so that we can help the client move towards change talk. And in addition to ORs, there are some other core skills that we can consider. One is really attending to the language of change. So throughout the entire process of engaging clients, we want to be paying attention. Are they primarily stuck in sustained talk? Are they engaging in change talk? And if they're engaging in change talk, what type, right? Are they talking like they're ready to go kind of change talk, or is it more of I'm in preparation stage change talk? We want to really pay attention to that. And ultimately our goal is to help move from more sustained talk, less change talk, to more change talk and less sustained talk. And in addition to that, there's this added component of exchanging information with permission. This goes back to that collaborative lens that we really want to approach MI from, and it opens up the space for us to be able to share our expertise and for the client to share theirs back. All right, so as we've kind of covered already, that an important component of MI is really eliciting this change talk. This is a key component to that shift towards commitment to change, so the action of change can happen. And there are many different strategies we can use to elicit change talk. It's asking questions, it's using the reflections or our ORs, but there are also different strategies within MI that we can use. One of my favorites is the decisional balance. You can see that on the top right here, but it's just a fancy pros and cons list, right? It's one way to think about it, where we help our clients recognize what are the pros and cons of staying the same and what are the pros and cons of change. For many folks, they don't necessarily give themselves opportunity to think about the pros and cons of both. So it really opens up an opportunity to see things from a different perspective and to open possibility for change talk. There's also change rulers. So you can see an example in the bottom right here, but the readiness ruler of like, how important is this change to me for you? So we can use readiness rulers to kind of gauge where our clients are at in terms of their change talk. And again, we can use different questions within the readiness ruler to move towards change talk. Other components that help us move towards change talk are explorations of goals, explorations of values. There's several values exploration worksheets or activities that you can find online that are really helpful. But ultimately, it's what strategy can we use to help move our client from thinking status quo to thinking about the possibility of change. All right, so that was a super quick look at MI, but let's transition and talk about what are the benefits of utilizing motivational interviewing with older adults. There are a multitude of benefits. Let's start with recognizing that MI is a collaborative approach. And we know from experience and from the literature that maintaining a sense of autonomy is an important component for older adult clients. So this collaboration allows for that. It's built in. In addition, it's a partnership. We're aligning together as partners to work towards a shared goal. And this allows for increased level of comfort, which means that our older adult clients may be more open to opening up. In addition to that, we know that there's a focus on increasing motivation to change. And depending on life cycle, the development across the life course, this may be a strategy that really helps our older adult clients who feel overwhelmed by regrets or guilt or any of the heavy stuff to really find that excitement about what their life plan is, to really reconnect to their purpose and meaning of life, and to give voice to their own self-exploration in a way that they may not do otherwise. And we are really focusing in on resolving the ambivalence. We're going to give explicit space to give voice to that, which if we think about our older adult clients, many older adult clients are navigating multiple intersecting issues. MI can handle that. it can navigate alongside those multiple intersecting issues and give voice to them. And it's a flexible model. So while there are processes, while there's this outline, it's flexible, it's person-centered. We really want to aim to adapt the model so that it fits for each of our clients or our patients. So it's argued that there are minimal adjustments that are needed from basic training. One suggestion that I've seen in a few different articles in the literature is that one adaptation for us to consider would be slowing MI down a little, maybe using more repetition that would help with information retention for older adult population. And we know it's beneficial because findings have shown positive impact across different health domains in our older adult population. And in addition to that, if you look at the current status of empirical research that's out there, there have been many applications of MI in different specific topics that are important within our older adult population. This includes things like fall prevention, physical activity, it's connected to that, medication management, which includes medication adherence, but also medication misuse, oral health, chronic disease such as diabetes, risky sexual behavior, and then other factors that were infused in all these different articles. But what research is saying is that MI versus no MI are, the samples are seeing improvements in their change behavior. So for instance, for falls prevention, folks are more likely to adhere to a falls prevention protocol after receiving MI versus no MI, as an example. And what we've seen more recently in the literature is that we can use various modalities to use MI, right? We know that it can be used office-based. There's several examples of it being used, especially in primary care, but it can also be used via telehealth or like web-based modules even, that there's been a lot of different applications. So we can reach more people, which is really neat. And while most of the, I don't want to say older literature over the past decade is focused more on primary care settings or more on inpatient or reaching older adults who are connected to an institution in some way, there is this trend in the literature towards looking at community dwelling older adults and how MI might be helpful with physical activity or reintegrating after injury. Which I found a few different study protocols that look pretty exciting. I can't wait to see what the results for those are. But we have to talk about biases and limitations, right? So when we look at motivational interviewing research across the board, there's tons, right? Thousands of articles, over 200 clinical trials. There's lots out there. And older adults often are not included as a focal population or at all within these particular studies. There are some studies, but we could benefit from more. In addition to that, there is missing literature and really examining MI with other risky behaviors among older adults. We know MI comes from the addiction field, but there isn't much out there in terms of MI and substance use for older adults. And there's not much out there that really dives into additional aging factors and considerations of additional aging factors like cognitive impairment, dementia, and different settings. So if we think about long-term care, those would be really helpful pieces for us to know. And while it's been suggested we need minimal adaptation to use the model, there's not much research out there that's really telling us what adaptations would be beneficial for this population and how could we make nuanced changes that are going to make this work even better for this population. And one other caveat, because I think workforce development is so important, is that there's also more emerging literature on training using MI with older adults. Especially, here's a tangent on my tangent, but there's definitely this growing literature on SBIRT specifically, but there's literature out there suggesting how we can infuse motivational interviewing into our training protocols when working with older adults. And that's just a little extra nugget of information for us to use in our work and training. And there are so many resources out there. We zoomed through we can spend hours and hours talking about motivational interviewing. I encourage you, if you are interested in learning more, to check out, these are just a few resources that you can check out in your free time. And then there's all kinds of books that you can add to your book collection. I would say my favorite's probably the top right one. That's the new edition, just came out, I think, last year. But Motivational Interviewing in Healthcare. It's an easier read. All right. Woo! I made it. Now we can open up to the fun part, which is discussion time. And I put a few questions up here just to kind of prompt us. But if there are other points that you want to cover, please do. If it's okay, if you put it in the chat or unmute yourself, what are some ways that MI might be helpful for you, or what are your takeaways, or what other ideas do you have?
So this is Suphasana. Hopefully you guys can hear me, but I would say that certainly with medication adherence, and that's a very common way that I use this.
So Heather Shaw has written into the chat, learning to work with more open-ended questions to facilitate the member actually opening up and sharing.
Thank you for those points. I appreciate both of those. Medication adherence, it seems that was one of those dominating themes out in the literature right now, is how do we really use MI for treatment adherence, including medications. And Heather, thank you for your point as well about the open-ended questions, given that space. And then Helen's question, I believe the slide deck will be shared with y'all after we get done meeting today. So you'll have access to the resource list there.
Yeah.
Any other thoughts, questions, or reflections? Oh, yay, Phyllis has something.
I have a question. Can motivational motivational interviewing help with a family member who does not realize or understand the limitations of their elderly parent?
I appreciate your question, Michelle. Thank you for asking that. And I would love to open this up for others' feedback as well. As a family therapist, I oftentimes think about it's not just about our patient, but it's about the ripple effect in their relationships. We think about motivational interviewing. If there's ambivalence, if the family member is experiencing ambivalence regarding what's going on with their loved one, we could use MI. If there's not ambivalence, if they're it's strongly in pre-contemplation stage, we may need to use a different approach to get them to a place of understanding that there is a discrepancy between their perspective and what's going on with their loved one. I wonder if others have thoughts.
Would you repeat the last thing you just said?
Yeah, I just wondered if others had thoughts that they'd like to add. Or Michelle, what are your thoughts about what I just said?
My mom, this is Terry or Therese. My mom is 80 years old and she's easily overwhelmed and she has multiple comorbid conditions. So I use motivational interviewing all the time with my mom to help her to think about other choices or other reasons that we might do something. I mean, I think motivational interviewing is terrific because it empowers the patient so much. So I'm not telling her what to do. I'm helping her think of ideas.
Okay, what about in the case of an elderly person? I'm not in the healthcare per se, in a facility, but I'm a healthcare giver. in that I have two people that I basically assist in their lives. One is 95, one is 85. And it's very difficult to get my 95-year-old to even allow her family members, or not family members, is one child, to like do her bills, do simple things that because every month she goes through this frustration of I've either lost something, or I've already paid this and now I've overpaid it, or I don't know what amount I'm supposed to pay. And she goes through that every month, but she won't relinquish to the family member the obligation to pay it. And I've helped her on several occasions to make adjustments for her bills, but then she panics later and changes it back.
So basically, she's scared. So she's operating out of fear and discomfort, like we were talking about. So maybe if you did like a pros and cons idea, or help to say, you know, could you explain to me why you feel scared about or nervous about the situation, just to open up the discussion and try to get her to explain how she feels.
Okay.
That's a nice suggestion, and something that
Thank you
I might
for that.
something that I might add. I don't know if it's helpful, but you know, I always first ask: is there an organic issue going on? Is there something else going on that might affect her memory or her processing? And so, even if you can't find the answer to that right away, you can presume there might be an issue. I always ask people what would reassure them. What would help you to feel that you have control over this, basically, or that you're able to do this, and wait and listen for them to answer. And if they don't, I make some suggestions of this has worked for some people and see how they respond. But usually, you know, even if it's every day, we go over your bills for just 5 minutes so that you know everything is in order. Or, you know, I show you a copy of your bank statement at the end of every, you know, week, whatever it is, that would reassure her. And it's also okay to ask people, do you think would be helpful, like knowing what her motivations are? Most older people, they do have fears about, you know, whether someone's dishonest or whatever, but they also want to leave a legacy of good habits if they have children or grandchildren. So asking them, is there something you would like to teach your daughter or whoever about how to take care of bills so that you can teach them? And most older people love to say, I'm teaching someone else. And sometimes that is, I found that that's helpful for them, and it gives them, it honors their autonomy and their power, I guess, in the situation.
What I find that is, oh,
Go ahead.
my name
I'm sorry, I
is
just
Helen.
said thank you for that.
My name is Helen, and I'm registered nurse as well as case manager. What I find in my practice that sometimes people would not like to say or realize that they lost their vision or they lost their hearings. And if they couldn't see the bill or they couldn't see the statement. So, you know, like maybe it's possibility to use different, like kind of glass or like whatever to enlarge the statement plan that she will be able to see it, because a lot of them has macular degeneration or cataract or whatever, you know, and they don't want to admit, because if they admit something, they don't have it, that means they are kind of losing their power and they're very scared. They're very scared. So that could be, you know, like some possibility. And also, because you're doing their bills, it's, you know, like we have a lot of unfortunate situations when family will get involved. So get family involved before some lawyers get involved. You know, that's my advice, because you know, you don't want to deal with families. You don't want to end up to be in very difficult situations. So my advice, get family involved. And, you know, some 95 years old can have some memory diminished, and it will be you know, like on you, that you're going to the bank, you're responsible financially. And I tell you, you don't want to be in this situation. No, trust me, you just don't. And I know you try your best, you try from your heart, but you know, family can say, who are you to my mother? That's you were able to, you know, like go and buy for her, I don't know, like a bread or what, you know what I mean? Like sometimes situations in real life is not favorable for people who like to do the best. So try to like kind of organize that it's going to be less financial kind of you know, on you, because
Thank
it can become very awkward for you. And you know, like I work 20 years in home care, trust me. It was all kind of awkward situations for people who wants to do the best, who try to work so hard, and you know, like, but reality sometimes very scary. So
Thank you,
try to
Alan.
get this financial responsibility off you. It's not good one. It's not good situation.
Thanks, Helen, for
Thank
sharing
you,
your
Ellen.
perspective on that. So Julie wrote in the chat, she says that as an RN case manager, I think MI can help when my members are dealing with transitions, right? So she says most of them know they need to make the change for their own health and safety, but they're ambivalent about taking those steps away from being totally self-sufficient and independent.
These are all such great examples and questions. I think